So we're talking about this book, and given the diverse crowd, I'll make a popular scientific summary, and then we'll have, I'm sure, the scientific discussion afterwards. So here's my idea. First, I'll make some additional comments about the specific part of value-based healthcare that I have studied in the thesis, just to add to what Carlotta was saying. And then I'll raise some reasons or question why it would be relevant to ask whether this works. Then I'll tell you what I did and what I found. And finally, I'll share some thoughts about what I think that this means. So this, I would say, is the core idea of value-based healthcare. In order to be very good at something, you've got to know what it is that you want to be good at. So if you try to optimize something, you will become very good at that, but you might lose what is really important if you're not focusing on the right thing. Then, of course, one wonders, how do you know what is the right thing to focus on? And I'm going to give you the answer that value-based healthcare provides. So if a person gets a disease and seeks care, he or she will hopefully be cured and everything goes back to normal. Then value-based healthcare says that there are three areas, so to say, that are important here. First of all, how healthy does the patient become? Are they alive? And what is their health? So what kind of pain status or movement do they have? So that's one area. And then it also considers the time before reaching this. So how long does it take to reach this health status? And are there events during this time that harms the patient, such as an acquired infection from healthcare or that kind of disability? And then as a third area, it considers the things that happens after the health status has been achieved. So how sustainable is this? Does it come back, and are there long-term side effects of the care that has been given? And value-based healthcare makes the argument that this is the result of care, and everything valuable that you do in healthcare, if it is valuable, it will affect these categories. That's what we say. But these are rather technical, so how would this be done in practice? Well, one way of doing this, and the recommended way of doing it if you're interested in patients' perception of their health, is to use standardized instruments. So these are instruments that are developed for research purposes, that asks a set of questions and then calculates this into a number. You can use this to track how well you're doing. So you would hand this to the patients at different states, and then you know whether you're achieving what is important. So this sounds very reasonable and intuitively true, but does it work? What if, for example, the course of the disease looks like this instead? That you fall ill and then you get better, and then you're ill again, and then you get better. This is what we would call a chronic disease, and healthcare has to manage this type of disease too. It's very difficult to see where it is, where would these brackets that I was showing before, where would they fit in this picture? So healthcare usually manages this with annual checkups, trying to keep track, adjusting therapy. But there's clearly something missing here in terms of how value-based healthcare will fit with this type of care. In this thesis, I was curious about three assumptions made by this theory. But first, we looked at the literature to see what has happened to this theory. Is it that other researchers are very critical and trying to evaluate it and trying to improve it? Or is it that they are just using it, or is it that they are just commenting on it? So this is the first thing. But then we looked at three assumptions. So the first one concerns whether it is really true that any valuable change in this system, if you make a change that you know is valuable, for example, to patients, does it always happen that it affects these three categories? Then I was curious about these specific categories. Is it true that everything that is important to patients fit into these three brackets or three categories? And then finally, also wondered about these standardized instruments that are developed for research. Can they really unproblematically be transposed into the care setting? So the aim of this thesis was to assess these assumptions, and due to the problems or questions expected in chronic diseases, we wanted to do it there. And we looked at a specific chronic disease called rheumatoid arthritis, and it can look very different in different persons, but I'm going to give you three symptoms just to give a picture of what it might be like. So first of all, and maybe the most known or common symptom is pain in joints, and usually several joints at a time, and try to get treatment that will prevent swelling and pain in the joints. And if you have a pain in one joint, you can give an injection of medication in that specific joint just to calm that down. But also stiffness after longer periods of inactivity. So typically in the morning, it will take half an hour or more before you feel like you're up and running. And finally, tiredness. And this is not like, oh, I slept bad this night, but rather a more intense tiredness that does not get better when you rest. So as you can imagine, this pain and this tiredness has profound effects on every part of life. And rheumatoid arthritis also have this kind of pattern where you're better and then you're worse, and you're better and you're worse. Okay, so let's look at what I did. So this was done in 4 separate sub-studies, and I'll be going through them one by one and telling you what I did and what I found. So first, the literature. And here we were curious about if value-based healthcare had been critically applied, or how has it been understood by researchers. So we identified the article that was most cited, that is most written about in the academic literature within value-based healthcare. And then we looked at all the papers talking about this specific article. And in these papers, we found the section that talked about the other article. And this happened 255 times, so I think it was around 180 articles, something like that. And then we connected this to the concept that they were talking about in value-based healthcare, and we made an assessment about if they were critical of it, if they had even understood, or showed, I should say, that they had understood the concept. So here's what we found. Here I'm using the solo taxonomy scale from education, rating the understanding. So at the top we have no idea. That is, you basically misunderstood what this concept is about. And at the bottom we have a critical perspective. We're trying to extend the theory or apply it in the context. So it turns out that about 1/4 of the researchers talking about this article do not understand the concept that they are referring to. And no one, at least in 2014 when we did this study, try to develop it or improve it. So what about this idea that every valuable change in care will affect these outcomes? Here, we made a change in the system of care. So we had two groups. One group had received standard care with annual checkups, and in the other group we removed all the annual checkups and asked the patients to contact healthcare when they felt like they needed care. And this is known to be important and empowering and valuable to the patient. And then we were curious, is it as predicted by value-based healthcare, or at least the interpretation I'm making of value-based healthcare here, that this would affect the outcomes and make the patients healthier? Here's what we found. So this is the 1.5 year of the time when we, on the x-axis, when we run this trial. And this thick purple line shows the difference between the groups. So the higher up it is, the healthier the standard care patients are compared to the other group. And the lower down, the healthier the patient-initiated care patients are. This shaded area here is what's important. It's a 95% confidence interval. This means that if you took all the patients that are similar to the 131 that we studied and did the same to them, I am 95% confident that the line I would see would end up within this shaded area. And this means that it could be that it's right around here on the 0 line, that is, there is no difference between the groups. Or it could be high up here with a significant better health for the patients receiving standard care. However, not as I would argue predicted by value-based healthcare, an improvement in outcome of the patient-initiated care. Okay, but what about these three categories, these three brackets? These persons with rheumatoid arthritis value something that does not fit easily into these categories? So here I interviewed 22 patients, and I looked for counterexamples, so to say, and also try to sort them into this model and see if I could expand it. I'm going to start off with a quote that aligns very nicely with the model. So this has to do with these injections you give into the joint that I was talking about. And it has to do with time, how important it is to receive care in time. You must get the aid when you have pain. You cannot say to a rheumatic person, we only do injections Tuesdays and Fridays. Such nonsense. Who even came up with that? It's not a rheumatic person who's come up with that. It's a healthy person. And then I'm going to show you two counterexamples that could fit. If you really want to squeeze them into the model, you can expand it and make them fit, but that would not naturally at least fit in these three categories. So this one has to do with predictability of the disease. It's so hard that this disease is tricky. Also because one day maybe I'm quite restless, the next day I'm really bad. I do not know myself, and that I think is tough. Then a final counterexample that has to do with continuity of care, that is to see the same healthcare personnel. If I go to the healthcare center with tonsillitis, I do not care the slightest whether I have met the doctor before. But when it's a chronic disease, and it is medicine and hospital treatment, it's so wonderful to have this. And then finally, these standardized instruments. What about them? Can they be used? So here I used a similar strategy. Interview data from 40 patients or persons with rheumatoid arthritis, and we looked at a specific scale that measures function. This is called the Health Assessment Questionnaire, and I'm going to make 2 examples. So here's one question in that scale. Are you able to reach and get down a 2-kilogram bag of sugar from just above your head? And then you rate this on a without any difficulty, with some difficulty, and unable to do. Another example, are you able to take a tub bath? And it's the same rating. So it's 20 questions just like this, and then it's calculated into this number that you can use that claims to capture function in these patients. Here's what one person said about them. Are you able to take down a pack of sugar? It's completely irrelevant to me. Can you bathe in a tub? I don't know. I don't have one. It appears to be designed for a specific type of rheumatism, age rheumatism. Not for us who are young and have a completely different situation. I'm going to get a bit more general and just talk about the kind of problems that were noted with these questions. And in this context, items here means the questions in this game. So either the persons felt like the question that was very important to them was not in the scale, so they wanted to add questions to this scale. Or they felt like the questions were unclear, so they didn't know how to respond. Or they felt the specific question was unnecessary. And this is what we saw in the previous quote of the girl who didn't have a bathtub. Or they said that the questions were too static, so they might have been relevant earlier, but they were not so anymore. So what does this mean? So it seems like researchers have not assessed value-based healthcare. And this is what we tried to do. And these 3 assumptions that we tested did not find support in this specific disease of rheumatoid arthritis. I'm going to repeat. The valuable intervention, or the intervention that was valuable that we are convinced are valuable to patients, did not affect outcomes. So it does not necessarily do that. These outcome categories, the brackets that I showed you, they do not necessarily capture everything that patients value. And standardized instruments are neither necessarily aligned with the patient's perception of this outcome. So this means that some claims of value-based healthcare are not universally true. And I would say that thus we have to be very careful and critical of value-based healthcare and assess it critically together with patients.